the Chair's question about have the steps to mitigate those concerns about bones been successful, can you explain how you know that? Do you personally follow up with your GIDS patients kind of throughout the process or years later or when they're adults? And I'd just like to point out to the panel that Kira Bell is sitting behind you, and you were mentioning earlier that all of the processes have been resumed when treatment stopped. I think she and her court case would probably take issue with that, as would other detransitioners. But could you just explain how you know those calcium bone levels have resumed or been okay?
Thank you. My comment originally was with children having precocious puberty treatment, not necessarily in the gender field. Can I clarify that?
Yeah.
I know there are some situations where we don't know the full outcome in terms of every person who's received puberty blockers from the trans field. We don't know all the details yet, so I think that's fair. So I can just clarify that, please. And in terms of the knowing about bone health as a sort of marker of, I suppose, biological effect, well, yes, we follow all the children, young people prospectively, so obtaining data and obtaining them monitoring on a regular basis. We can see what happens as they go through the various steps and stages of treatment. We work in very similar practice to other major centres around Europe in that regard, and the information has already been in the public domain and published, certainly from clinic in Amsterdam, and our current researches, which we're doing in parallel with them, actually mirror those findings.
Wasn't there a study in Sweden that showed that bones were breaking quite often?
I don't know about bones. Breaking is very unusual to happen in adolescence. I think, as Professor Giordano said, that's not something that we would see because the bone, even if there is a change in bone density, it almost rarely gets below the range or into the range you'd expect fractures to occur.
Dr. Butler, what outcome is prescribing puberty blockers supposed to achieve other than precocious puberty? I know we've touched on this a bit. I just want to drill down a bit on that.
Well, they've advocated as part of the process of managing the dysphoria in an adolescent young person, and as part of the recommendations, not only international but also from the service specifications from NHS England, to which we follow, who have asked that and have contracted with the various trusts to provide the service, that to actually begin to support the young people through their transgender journey, and this is one way of helping them in that regard.
Thank you. Do you know of any good quality evidence that Dr. Hilary Cass didn't look at that shows that puberty blockers achieve that purpose?
If I can refer back to perhaps some of the previous comments, it's about the type of measures that are used and how you're going to assess the evidence. The problem is, and I was working with Dr. Baroness Cass on the evidence accrual process through NICE, and it is very clear that according to the standard hierarchy of evidence, there isn't anything which would fall within, or a very minimal amount in that high level of categorization, most of it being observational, in other words, just simple reports of what's happening at baseline or changes, but whether they're using physical or mental health measures, and that is again regarded as not sufficient in that categorization.
Thank you. Can I just ask you a bit about your time at GIDS? Why did you continue to prescribe puberty blockers when the preliminary results from the early intervention study in 2015-2016, which of course you were heavily involved with, didn't demonstrate clear benefit?
At that stage, the contract was within NHS England, who provided the framework for the service specifications. The contract was then through with the GIDS at the Tavistock, and the endocrine clinics provided support from that. So that was within the bodies and within the NHS England service specifications and their commissioning.
Okay, why were the results not published till 2020?
Well, I wasn't directly involved in that study myself, but the issue around a lot of studies having been involved with what are called longitudinal long-term studies in children, it takes a while to accrue the information and also collect the evidence of or information on effect or changes over time. And that was, according to the leaders of the study at that stage, that's the report that was given to the Health Research Authority. I mean, currently you're probably aware, there's a National Institute of Health Research funded study looking at the longitudinal outcome of gender identity in children called the LOGIC study, and that has been ongoing for a number of years now. And clearly that's although there's some preliminary information coming out, that will help, I hope, provide answers to some of the questions that the committee has. But that's going to take some years before the information is sort of analysable.
Thank you. Dr. Grossman, you mentioned before about young women. You were a bit concerned about the number of young women who've been being prescribed. Given that the Tavistock GIDS found that a high percentage of its patients had an emergent same-sex orientation, I've written down that it was 68% of girls and 42% of boys, i.e. people who are just likely to grow up gay or lesbian. Are you concerned that puberty blockers are being used to change children from being gay or lesbian to being able to pass as straight or members of the opposite sex? And do you echo the concerns of some of the former GIDS clinicians that they were transing away the gay, in their words?
So I understand your question. Yes, personally, I am concerned. And again, I speak as an adult endocrinologist, not as a paediatrician with any great experience of paediatrics. But my concern is that I have quite a number of daughters. Adolescence, childhood, is quite a difficult time, highly confusing for quite a lot of children. We know anorexia nervosa is really quite a common problem now in young women, of uncertainty as their future, their sexuality. And my concern is not the endocrinology per se. I think as technicians we're very competent at doing that, but as the assessment of these young people who will put on a trajectory that takes them automatically into a transgender state. The original idea, and which I think some 10 years ago, I was asked by a newspaper how I felt about the concept of puberty blockers, which at the time I thought was not unreasonable. The time to consider, time to reflect, maybe for 6 months, that you would put everything on hold, and then see which way it's going forward. My concern about the work from the Tavistock and the Portman Clinic was very much that they were put on this conveyor belt and automatically transferred into a transgender state at the end with, I think, was certainly inadequate follow-up, but probably inadequate assessment in the first place of these young women who are clearly in a difficult situation. There may be many other problems going on. We know about problems with possible neurodivergence and autism, and that these were not properly explored. So my concern for the future is that there may indeed be a small cohort, and I would imagine it's probably small, of young women who wish to be transgender and which pubertal blockers may be of assistance, but we're not adequately assessing the probably much larger number of young women who, with adequate counselling, psychological support, would eventually decide they wanted to say cisgender.
Before you move on, could I just offer that same question to Professor Butler and to Professor Giordano, please?
Yeah, that's what I was going to do.
I think, absolutely. I think as far as the numbers who were being referred to the GIDS, as everybody knows, went up exponentially from about 2010, 2015 onwards, which there is no, because that was happening across Europe and across the developed world, there isn't really a clear explanation for that. It is fair to say, and I think everybody realises, that the GIDS was overwhelmed by the numbers of referrals there because it was set up as a highly specialist service, as was the endocrine support. And as Professor Giordano explained, that as the numbers increased in GIDS, so did the proportion who were referred to endocrinology. So it was, again, a much tinier minority of those referred to GIDS, particularly those who were birth-registered females, actually ever got in the way of endocrinology. So we were not seeing them, and they were not. And furthermore, just to make it clear, because they had already gone through their biological puberty, there really wasn't a place for puberty blockers. Other ways of managing distress, say over menstruation, other hormonal methods.
Thank you. Professor, did you want to come in?
Yes, 2 points, I think. One, I would like to comment on the conveyor belt concern. I can't comment on how the services were stretched and how the assessment was in fact carried out, because I wasn't a part of that. But the international consensus and the recognized practice is to consider puberty blockers as a complement of a number of other psychosocial measures only and only in those cases where the young person suffers from what was called until recently strong and persistent gender dysphoria, which would not be alleviated by other means. In this cohort, persistence and persistence studies which have been conducted since at least 2016, it appeared that those individuals who, after the onset of pubertal development, would experience and continue to experience strong and persistent gender dysphoria would nearly always become later transgender applicants for medical treatment for transition, regardless of whether they had been given puberty blockers. So the correlation between puberty blockers, prescription, and later transition is not causation in this case, to my mind. It is most likely need that explains that correlation there. So that's one point on the conveyor belt. The second point concerns the benefit and your claim, Honourable Ms. Duffield, that the study published from the cohort, from the clinical trial concerning Tavistock, didn't show benefits. So how that puberty blockers don't have benefits in terms of suspending puberty is like to say, to deny that the earth is spherical. For someone who is distressed by pubertal development, suspending pubertal development is clearly a benefit. The question is whether that benefit outweighs the risks and whether that benefit is justified. And when the measures of benefits are taken, sometimes they are taken in a questionable way. For example, one point that has been made is that, and this was one of the results in one of the York reviews that then fed into the Cass review. Puberty blockers do not have proven mental health benefits because at follow-up there was no evidence, so the York study reads, that the mental health had improved or worsened. So the York study found that the people who had taken puberty blockers and compared pre and post found that having been on puberty blockers didn't improve their mental health nor worsened it, and took it as a suggestion that therefore what are you giving puberty blockers for? But actually from a clinical perspective, stability, not worsening, can be quite a good clinical outcome, because you can predict that a dysphoric adolescent will get worse and worse mentally. So stability can be a good clinical outcome. So you need to ask the correct question to have the correct answers and to understand benefit in the correct way. And the same is when people ask, well, it's not really beneficial because it doesn't have any statistically significant impact on gender dysphoria. That's not what puberty blockers are intended for. They're not a treatment for gender dysphoria. So if you measure the effect or the benefits of puberty blockers on reduction of gender dysphoria, you're clearly not going to find a benefit there. So I think questions need to be pertinent to have pertinent answers.
Thank you very much. David?
One final question.
You've had 7, which is nearly twice the amount of every other member,
Right, thank you.
unless it's super urgent.
It's just based on something Dr. Butler said about the Tavistock Clinic being overwhelmed. Was it your experience that it was overwhelmed with more autistic patients? Because Dr. Grossman mentioned autism as being one of the comorbidities.
Well, with numbers of referrals, and NHS England were aware of that, but to my knowledge, no actions were able to deal with the expansion of the service at that stage.